Good afternoon, everyone, and thank you for joining us for the Medical Board of California's Midwifery Advisory Council meeting. This meeting is being conducted via WebEx. Public comments will be heard for each agenda item for individuals wishing to speak. To be ready for public comment, we ask that you please ensure your comments can be heard clearly by being connected to the audio of this meeting through the proper method. If you are having difficulty hearing the audio of this meeting, it could be because the device you're connecting with has bandwidth limitations. If you do have difficulty hearing the audio of this meeting using your device, please click the ellipsis button at the bottom of the WebEx application or the audio and video menu item at the top of the WebEx application, and then select Switch Audio. You'll see an option to call in and will be provided with a telephone number, access code, and attendee ID that can be used to connect to the meeting audio via phone. Using the information provided, it will automatically disconnect your device's audio and connect your phone to the name you joined the meeting with. By using this method, if you are having difficulty with audio problems with your device, this will allow you to still participate and hear the audio of the board meeting. Please see the instructions on how to connect link on the last page of the meeting agenda for step-by-step WebEx instructions, including screenshots. Thank you, Ms. Weisner. You can now start the meeting.
Hello, everyone. It is now 1:03 p.m. and I'd like to welcome you to the Advisory Council meeting for the Midwifery Advisory Council. My name is Madeline and I am the chair of this Advisory Council. Since this meeting is being conducted via WebEx, I will ask all MAC members and speakers to announce themselves by name before speaking for clarity of the official record. All MAC members are able to unmute themselves to speak during the meeting. Please place yourself back on mute when you're not speaking to reduce background noise for all participants. Following such online meeting etiquette will ensure the best audio quality for everyone. During each call for comments from MAC members and speakers, we will ensure that all comments can be accommodated and heard before proceeding with the agenda. During each agenda item, the host will activate the Q&A and hand-raising features on WebEx and will ask anyone wishing to make a public comment to indicate so by replying yes in the Q&A window or by using the hand-raising features. The host will then call on individuals who indicated they wish to make public comments by name. When called upon, the host will unmute the microphone of the individual and they will be able to make their public comment. After the comment, the individual will be placed back on mute. Please see the agenda at mbc.ca.gov for WebEx instructions on how to connect from the link on the agenda and additional instructions. The board's IT staff will very patiently assist me with receiving the public comments. And MAC members, as a reminder, during today's meeting, any items requiring a vote will be done by roll call vote. This means that once a motion is made and seconded, Ms. Moriarty will call each of our names individually to request our vote. I would now like to call the meeting to order and ask that Ms. Moriarty please call the roll call. Please call the roll.
Thank you. Faith Freeman.
Present.
Dr. Kenneth James.
Here.
Tamara Robertson. Karen Rosley.
Present.
Mason Wilson-Tenev.
Present.
And Madeline Weisner.
Present.
Thank you. We have a quorum.
Awesome. Cool. Moving to agenda item number 2, public comment on items not on the agenda. Are there any public comments?
As Ms. Weisner mentioned there, you can use your hand-raising feature there in WebEx. There is this audience Q&A in this Slido window if you'd like to use that. And if you're in a call-in-only line, you can press *3 in order to toggle raising your hand. Everyone, a few seconds here to see if anyone would like to make a public comment. Okay, I'm not seeing any requests at this time, Ms. Weisner.
Sounds good. Let's move on to agenda item number 3, which is the approval of the minutes from the April 3rd, 2025 Midwifery Advisory Council meeting. The board received one request to edit the minutes on agenda item number 2. In the first paragraph, the minutes state that Saracoso Community College secured a grant from HCI for $5,000. The grant is actually for $500,000. Are there any other additions or corrections to the April MAC meeting minutes from the members? Doesn't sound like it. May I have a motion to approve the minutes from the April MAC meeting as corrected?
I'll make a motion to approve.
Anyone
Kenneth.
second?
I'll second the motion.
Awesome, thank you. Are there any public comments?
Yes, if you'd like to make a public comment for agenda item 3 here, please do so by typing anything in that Q&A window or using the hand raising feature. If you're on a call and only line, you can press *3. Give you a few seconds to see if anyone queues up. Not seeing any requests at this time.
Ms. Moriarty, could you please perform the roll call vote?
Yes, Faith Freeman, Dr. Kenneth James,
Approve.
Karen Rosley,
Present.
Mason Wilson Tanev,
Present.
Madeline Weisner.
Yes.
Thank you.
Awesome. The April
May I
2025.
get clarification?
Yes.
A couple members said present, and I just want to confirm that you are voting to approve the minutes.
Yes, approve.
Ms.
Sounded
Rosalie
like
as
it.
well?
Yes.
Thank you.
Cool. Yes. Awesome. So thank you, Ms. Webb. The April 2025 MAC meeting minutes are approved. Moving on to agenda item number 4, report from the Midwifery Advisory Council Chair. I will be giving this report today. First off, I want to begin this report by announcing again that the Medical Board's enforcement program has consultant and expert reviewer opportunities available for licensed midwives. Consultants evaluate the specific standard of care issues raised by a complainant to determine if further investigation is required, whereas expert reviewers provide expert reviews and opinions on board cases and testify at administrative hearings. For eligibility and application requirements, you can go to the board's website at www.mbc.ca.gov and click on the enforcement link and then the links to the medical consultant and expert reviewer programs. Moving on to my report, first off, I would like to give a warm welcome to Karen Rosley to the MAC. Thank you for joining us. It's been a long road getting you here, but I'm looking forward to working with you. Thanks for being here. Next, throughout this year, really since April, I've received a handful of reports from licensed midwives and their clients throughout the state in regard to difficulties with birth registration and Social Security enumeration. We all know that this has been an issue for decades, like as long as licensed midwives have existed in California. However, it does seem that the current political climate has further emboldened individual employees in some counties to restrict filings for licensed midwife clients and babies born outside of the hospital. Babies born at home or at birth centers, particularly birth centers that are exempt from licensure, to my understanding, are still unable to receive automatic Social Security enumeration. And in most cases, those families have to present with their babies to these offices shortly following the birth. I think that we can all understand that this is really disruptive, both to like postnatal healing and bonding with a newborn, but also it poses a safety issue to these families and their midwives, particularly in light of the presence of immigration and customs enforcement at and around vital records and Social Security offices. In particular, I received a couple people in Los Angeles and in Sacramento with these concerns. I would encourage midwives working with all of their families, and particularly families who are concerned about this, to contact their individual professional organizations such as CALM, as well as to contact CDPH for vital records issues and their individual SSA office management for Social Security issues. Families with concerns in regard to documentation or who are afraid of being engaged by ICE will also likely benefit from making contact with an immigration attorney to clarify what their rights are and any relevant next steps in getting these essential documents for their children. I'd also urge mothers to please not attend any of these appointments alone, and for midwives to very clearly document any issues with this process in the client's records. And I'm happy to field your grievances as well about this. It's very serious. In better news, in June, the midwives at Santa Barbara Birth Center were highlighted by the International Confederation of Midwives. Very cool, as a really beautiful example of midwife-led care in our state. In particular, this online feature focused on the center's practice model and has very beautiful photography with it as well. So you can read about it if you're curious at internationalmidwives.org. One of my pals in New Zealand was like, "Do you know these ladies?" And I think that they're from near you in the United States. Yes, California midwives are being featured on the international scale. So great work, everybody. In July, the journal Birth published consensus guidelines for intermittent auscultation in United States community birth settings. These guidelines provide consensus recommendations for intermittent auscultation, also known as listening to fetal heart tones with a Doppler, in the community birth setting in the United States. These guidelines were created over the course of 23 work group meetings involving educators, quality improvement experts, practicing midwives, and midwifery leaders, including those in California. And they might be helpful to your practice. The reason that I share them here is that now that these guidelines are in existence and have been really well disseminated, every California midwife should have a clear understanding of these guidelines and should review their own practice and modes of documentation and recommendations to see at least how they align with the consensus guidelines. They do discuss times when intermittent auscultation is no longer appropriate in labor, and indications for transfer are listed. There are implications for this from an investigation or from an enforcement standpoint, given that we don't have actual regulation that says when to do those things. As with any new guidance, this publication has the potential to raise the bar of what's acceptable in terms of practice in California, in community birth specifically. So just wanted to give everybody a heads up about that. You can do a search for intermittent auscultation consensus guidelines and it comes up. It's free, and like the full text is available. Really recommend you check it out. Let's see, in July, the California Maternal Quality Care Collaborative, also known as CMQCC, released their strategic plan and a request for public comment and feedback for the HRSA-funded Maternal Health Innovation Program. This is a statewide initiative that aims to reduce severe maternal morbidity and mortality. And midwives were unfortunately only mentioned once in that entire strategic plan. Both CALM and CNMA collaborated to provide feedback to CMQCC about this in regard to recommending that all recognized care providers in birth settings are appropriately reflected in statewide planning. And of course, they reiterated that midwife-led care is a cornerstone of all health systems with better maternity outcomes than the US. In August, new research from Spetz et al. Entitled Direct Entry Midwife Education, Practice, and Patients in California reinforced the urgency of our maternity care crisis in California. This report stresses that multiple strategies are needed to expand and rejuvenate the midwifery workforce and ensure equitable care. This piece also centers California licensed midwives as playing a key role in offering families a choice of birth setting and model of care, and is very supportive of direct entry midwifery practice, such as licensed midwife practice. Supports establishing policies that are supportive of community births, and has a few interprofessional collaboration suggestions as well. More interestingly, the study looks into attitudes and demographics of direct entry midwives, as well as the perception of whether or not licensed midwife skills and the role itself is appreciated. And I'm sharing this because I think midwives should look at it, but also all of our stakeholders, policymakers, certainly our clients, our families should look at it. It's extremely valuable research, and it's available in full text on PubMed. It's a good read. Been reading a lot since the last MAC meeting. In even more positive and very cool news, 600 nurse midwives and CRNAs went on strike on Monday. I don't know if anyone noticed, for better working conditions and compensation in the Kaiser Health System. Kaiser is the largest healthcare provider in California and is also the largest employer of midwives in California. And these facilities are often utilized when licensed midwife clients need help from hospital-based providers because they offer midwife to midwife consultation and collaboration with help from physicians. I just wanted to uplift these very cool workers who organized, first of all, like they unionized, and then they organized this strike, and they're continuing to work to keep the best, most well-rounded possible version of midwifery care in California, including hospital-based midwifery care. Very, very cool stuff. Keep an eye out on that. As always, if you're a licensed midwife or a consumer, or if you're another stakeholder, I encourage you to make public comments at these MAC meetings. And you can also reach out to me directly. I'm online. You can easily find my contact information. So this concludes my report. Are there any questions or comments from the MAC members on this report before we move to public comment? Nothing. Cool.
Is this appropriate time to make a public statement, or would I want to wait till later for that?
You know, I talked about you in the chair report, and so I don't see why not. I don't see why you couldn't comment on that.
Okay. Bear with me, because I actually typed something up after reading the document that you addressed, where midwives were only mentioned once. I noticed that right off the bat. And so I guess my consumer statement would be: women want midwives to be integrated into the healthcare system because they provide high quality care for mothers and babies. Without them, maternal and infant care status in the US will continue to degrade. My questions as a consumer are: why is the US wasting such a valuable workforce when midwives have consistently proven that midwifery care outcomes are better for low-risk births? Why do we continue to support a model of care that reinforces costly, unnecessary interventions and wastes valuable resources? When will the US take a cue from other countries that do better by utilizing midwives to their highest extent? The Netherlands, for example, has successfully integrated midwifery care into their healthcare system and has normalized home birth, including a supportive process for transfer of care when indicated. And I noted a US News, June 4th, 2024, how the US compares to other rich countries and the CMS Strong Start study. And I'm happy to provide that so that it can be on record.
Very cool. Thank you. Are there any other questions or comments from the members on this agenda item? I kept it brief. You're welcome. Are there any public comments?
If anyone would like to make a public comment here on agenda item 4, please do so by typing anything into that Q&A box there, or you can use the hand raising feature. Or if you're on a call-in only line, you can press *3 in order to toggle raising your hand. Give everyone a few seconds here to see if anyone queues up. Not seeing any requests at this time. Oh, one just came up. Leslie Nelson. Leslie, give me a minute here to send your request. Leslie, you should be receiving that prompt on your end.
Great. Can you hear me?
We can, Leslie.
Yeah.
Please go ahead.
That was an excellent presentation. Thank you, Maddie. That was wonderful. And yes, I noticed, I just am saying that I noticed about the Kaiser here in Sacramento, Roseville midwives were out striking, and I had full intentions of showing up there and giving them support, but I got called away. Thank you. That's all I wanted to say.
Thank you for your public comment. At this time, I don't see any additional requests in queue.
Okay, thank you. Moving to agenda item number 5, I have another report from the Task Force on Medi-Cal related issues. This one is also brief. The Department of Healthcare Services, known as DHCS, was selected in January by CMS as one of 15 states to participate in the Transforming Maternal Health Model, also known as TMA. TMA is a 10-year care delivery and payment model designed to test whether effective implementation of evidence-informed interventions sustained by a value-based payment plan model can improve maternal outcomes and reduce Medicaid and children's health. CHIP expenditures, Children's Health Insurance Program expenditures. DHCS will be implementing TMA in California in Fresno, Kern, Kings, Madera, and Tulare counties. There will be 2 virtual meetings, one of which is tomorrow, and the second of which is October 1st, which I think are invitation only, but you should still go, that bring together a broad range of stakeholders, including providers, managed care plans, community-based organizations, and representatives from local and state agencies. So if you are a midwife in those counties, Fresno, Kern, Kings, Madera, or Tulare, or if you aren't in those counties, but you travel to those counties because there's no maternity care provider in those counties, please consider joining this meeting. You can find it online if you look up DHCS TMAH, TMAH. The postings and login information for those meetings is listed. In other news, in July, a concept paper was released by Department of Healthcare Services and other stakeholders entitled The Postpartum Pathway, which outlines a proposed measurable clinical practice approach that aims to support the delivery of what they term whole person care, addressing clinical and social drivers of health needs. The model is termed aspirational in the paper, and the intent for it is for it to be tested by various stakeholders such as individual health plans, hospitals, birthing facilities, primary care providers. The goal is for them to first determine whether it's even possible to offer this model before scaling it in the Medi-Cal system. Several midwives, including moi, were involved with the formation of this paper. And the paper itself, I am proud to say, uses the word midwife 16 times. The paper emphasizes coordinated team-based care, including the idea of a lead maternity care manager who basically coordinates all necessary care through the childbearing year, as well as data sharing, patient-centered and personalized care, patient education, and workforce development and support, as well as behavioral health considerations like screening for perinatal mood disorders and referral for behavioral health providers. The pathway does acknowledge the need for enhanced care through a full year postpartum. And it's very clear that this paper is an attempt to find like the lowest common denominator in maternity care and raise that standard to reduce people dying and people getting very sick after they have a baby and during their childbearing cycle. The report does point out that in California, a person passes away every 5 days from childbirth, from pregnancy, which is crazy to me. Because California has one of the lowest mortality ratios in the US. So on first impression, reading this, I'm like, all of the standards of care that they recognize and that they recommend are so far beneath the standard that all licensed midwives offer. So for example, like they're like, can we get one postpartum visit? One postpartum visit. Can anyone give this woman one visit after she gives birth, right? And as we know, licensed midwives are visiting people 5, 6, 7, 8, 9, 10 times after they give birth. You know, they're on call 24/7 for these families. So if you're intrigued, if you're moved, this full paper is on the DHCS website. It is called the Postpartum Pathway Concept Paper. I'll also note that it emphasizes like cost-saving, hands-off approaches to solving these problems that very clearly need to be solved with a hands-on approach, such as like mobile or like telemetry blood pressure monitoring, for example. For a paper that says that it's aspirational, it's still not aspiring to give these people actual healthcare providers. It's aspiring to extend the existing workforce, which is interesting. And they're going to continue seeking public feedback on this. I think that midwives probably have some really good input on it, and I would like to see even more input from midwives. Anyway, DHCS also specifically has reached out to me, as well as Midwifery Access California, wanting to know from licensed midwives taking Medi-Cal if they have heard of any issues with access to consultations from OBGYN, family practice, or MFM providers through the managed care, the Medi-Cal managed care, or straight Medi-Cal system. So for example, if someone falls outside the criteria set forth in our practice law, right? And we need, if we need them to consult with a physician, Medi-Cal wants to hear if that is impossible or if that is infeasible based on the payer. DHCS has a midwife information page on their website that has like increasingly thorough information about licensed midwives, which is very cool. And so if you are a midwife or if you are a client of a midwife with Medi-Cal who's had issues accessing physician consultation or physician collaboration, please reach out to DHCS. They need to hear that that's a real problem, okay? This concludes my Medi-Cal task force report. Are there any questions from the members, comments from the members? Are there any public comments?
So if you'd like to make a public comment here on agenda item number 5, please do so by raising your hand, typing anything into that Q&A window, or if you're on a call-only line, you can press *3 to toggle raising your hand. See if anybody queues up here. I'm not seeing any requests at this time.
Sweet. now we will move on to agenda item number 6, which is an update on midwifery related legislation with Mr. Bone.
Good afternoon, Madam Chair and members. For those who we haven't met before, my name is Aaron Bone. I'm the board's Chief of Legislation and Public Affairs. The legislature is about to complete their work for this year later on in this week, probably over the weekend. And I'm pleased to share the following updates on some pending legislation that may be of interest to the MAC members. First is AB 408, which is board-sponsored legislation to authorize the establishment of a health and wellness program that will lead to treatment and monitoring of the board's licensees and applicants related to substance use disorders or other health conditions that they may have that impair their ability to practice their profession safely. This bill has received substantial legislative support and interest throughout the year and will be further considered by the legislature next year in 2026. The next is Assembly Bill 55, which revises the licensing requirements for an alternative birth center with respect to the types of perinatal services that must be provided at that facility. Further, the bill requires the center to have a written hospital transfer policy, and at the time of transfer, the bill would require either the licensed midwife or the certified nurse midwife responsible for the individual's care to provide the hospital with all the patient or client's medical records that are available at that time, and to speak with the receiving provider about labor up to the point of transfer or any other information that's not provided that's relevant in their medical records. When providing an initial orientation to new patients or clients of the center, the bill would require them to be informed of the estimated time it would take to transfer them to a hospital, provide other related information, and include a signed acknowledgement receiving such information in the patient or client's medical records. The bill also updates a code section that authorizes Medi-Cal reimbursement to these centers by deleting the requirement that the center be certified as a comprehensive perinatal services program provider. It also states that the center must meet the standards for certification established by the American Association of Birth Centers as opposed to the National Association of Childbearing Centers, which is what current statute refers to. This bill was approved by the legislature earlier this week and is pending action before the governor. Next is AB 836, which creates a framework to conduct a statewide study on midwifery education. This will be led by the Department of Healthcare Access and Information, and findings of the study are intended to support the creation of a sustainable strategy that will develop the midwifery workforce in California and is reflective of California's racial, ethnic, linguistic, socioeconomic, and geographic diversity. The bill was approved by the legislature this week and is pending action by the governor. Next, we have two bills with the same number, Assembly Bill 160 and Senate Bill 160. They contain language that would authorize all the board's licensees, including midwives, to be enrolled in what's called the FBI Wrap-Back program, which notifies the board of federally reported arrests and convictions that occur after the individual is licensed. Under current law, we do a background check, with what involves a review of the individual's past criminal history. And then we will receive reports about our licensees related to arrests or convictions that occur in California, but not for criminal activity that may occur outside of the state. And this bill is meant to catch us up and get us into that newer FBI program. This bill would also impact the Osteopathic Medical Board, the Board of Psychology, Board of Behavioral Sciences, and other state agencies. That bill is pending approval from the legislature. It is likely to occur this week. Next is Senate Bill 626. Among various provisions, the bill requires healthcare practitioners, including licensed midwives, who provide perinatal care for a patient to screen them for a perinatal mental health condition, according to applicable clinical guidelines and the standard of care that is appropriate to the practitioner's scope. The bill requires providers to follow guidelines from ACOG unless those guidelines do not align with the provider's scope of practice. Providers who diagnose and treat an individual for such a condition must do so in accordance with the appropriate standard of care and may refer their patient or client to another practitioner authorized to provide this care if the practitioner wishes. This bill is in the final stages of the legislative process, but is not expected to be considered and possibly approved until next year. The next bill I want to mention is SB 669, which calls for the Department of Public Health to develop a 10-year pilot project to test a new category of perinatal service called standby perinatal services. This pilot program would be established in critical access hospitals in rural areas that have limited access to comprehensive perinatal care. The pilot program would involve up to 5 critical access hospitals, and it prioritizes hospitals in the counties of Humboldt and Plumas, and establishes various standards and requirements that a facility must meet in order to qualify. The bill requires the department to consult with a wide variety of stakeholders, including licensed midwives, to develop this project. Last bill on my list, Madam Chair, is Senate Bill 470, which would extend the authority of state advisory bodies like the MAC to continue to meet remotely like you are doing so right now. That authority is set to expire at the end of this year, but under this bill, that authority would be extended for 4 more years until January of 2030. That concludes my prepared remarks. Madam Chair, I'm happy to try to answer any questions.
Are there any questions or comments from the members?
Mr. Bone, could you just repeat the AB and SB numbers? They were the same for that FBI reporting bill that you'd mentioned.
Yes, it's AB and SB 160.
160, thank you.
Yeah.
I have a question.
Yeah.
For the perinatal mental health conditions bill.
Yeah, SB 66.
SB 666? No.
626.
626. So for SB 626, so it refers to the individual practitioner's standard of care, and licensed midwives within our practice law don't have, I don't think, anything about perinatal mental health conditions specified. Would this bill, if passed, become the main legislative authority on what we can and cannot do? Or would we be forced to follow ACOG guidance on perinatal mental health stuff?
You would not be forced to follow ACOG guidelines. The bill states that ACOG guidelines are the guidelines to be followed unless it's not consistent with, your scope of practice. So I think that covers. I think that covers the first question. I think your other question, more broadly, I don't know how to fully answer it, but there is existing law that the bill is amending that states that healthcare practitioners who provide, prenatal, postpartum, or inter-pregnancy care need to ensure that they are offered screening and or are appropriately screened for current law says maternal mental health conditions as opposed to perinatal. So there's some existing law that's already on the books that I believe is already relevant. My conversations with the author's office, their goal is to help ensure that more screening that's done appropriately is occurring.
Right.
And they were, during our conversations, they were very initially spending a lot of time talking about the ACOG guidelines. And one of the points that we raised to them was, well, ACOG guidelines are not going to be relevant for every practitioner that's out there. Certainly for midwives, and for, among other reasons, those ACOG guidelines have a lot of language related to, prescribing medications, which are, things that are outside the scope of many non-physicians. So we spent a lot of time talking with them about making sure that the bill was, inclusive and, and covered all the different types of, practitioners, that are out there. Earlier versions of the bill were also talking about the ACOG guidelines in a way as though like they were the standard of care, or at least it was kind of some could read it to be that way. And so we think the current version of the bill, the board supports this version of the bill, because it's about getting more screening done, and importantly, it helps to ensure that whatever care is provided, that where the law states that these providers should follow the standard of care. So it's just restating what existing law is. I hope that answers your questions. If not,
That is really helpful. That's really helpful. Thank you. I think when I've spoken with other midwives about like mandatory perinatal mental health screening, there's a lot of pushback because where do you send these folks? Where do you send these folks in a county with no obstetric provider and only a handful of primary care providers? Do you send them to the pediatrician who refuses to treat this because it's an issue with the birthing parent and not with the baby? Do you send it to a therapist that, is $250 an hour? Do you what is the pathway for actually following through on this screening, and how do you approach that ethically in a maternity care desert? I think that for a lot of our Medi-Cal members, especially when we have a positive screen and we send these people to get care, it's often harmful. Like, it's often more harmful than just telling them, like, you screened positive, congratulations, you're depressed and there's no treatment available, and so let's go outside of this system altogether. So I'm interested to see how this shakes out and how it's tested, because I think with any of these, there's the potential of it to come up in complaints and investigations, and I would hate for any midwife or any family to feel like their needs aren't being met with this, but I'm intrigued to see how it's tested in that process, and I hope it's approached with,
if it's relevant. If it's relevant, Madam Chair, the bill sponsors include Black Women for Wellness, Maternal Mental Health Now, the Policy Center for Maternal Mental Health, the Postpartum Support International California chapter. And so there's a real emphasis there on trying to increase, access to this care and screening for, marginalized communities. And so, but you're asking really great questions, Madam Chair, about where do folks go if they get screened, and have a positive screen. So a lot of that, of course, goes, beyond the scope of what this one bill is able to do. But, I think the board feels that this is an important, way to, highlight and underscore, the need for this. And for us as well, primary concern for the board is to make sure that care is being provided appropriately and consistent with, all the relevant standards.
Right. Do you feel like this would be an opportunity for a professional organization like Quorum, or even all of the midwife organizations, to get together and produce some sort of guidance? Or is that not?
That's a really intriguing question. So one of the other aspects of the bill relates to insurance providers, both HMOs and PPOs, and it revises some existing law about maternal mental health programs that need to be developed and promulgated by healthcare service plans, and as well as insurance products. So just thinking off the top of my head, Madam Chair, like those insurance providers might be a good way for the midwifery community to organize and provide information to and recommendations about what should go into. And again, the law is right now is changing from maternal to perinatal in the terminology. So I think that's something I have had at least one conversation with Calm, Ms. Davis, about the bill, and we were on a meeting together some time ago. The bill has a lot of support from folks in the maternal care community. So I think if you do if you're interested in reaching out to some of your contacts and some among your peers and related organizations, I expect you may find some awareness already about the bill, and maybe they have some plans that are comparable to kind of what you're thinking about.
Cool. So awesome. Thank you. I just had one other question about the FBI wrap back program.
Yeah.
How would that impact? So the medical board would receive these reports.
Mhm.
Would the medical board be sending information as well? Is it a two-way? Is it a one-way information stream?
If I understand your question correctly, and if I'm fully dialed into the way the process works, is that essentially after the individual is licensed, then the board would receive information from the FBI relative to an arrest or a conviction that gets reported to the FBI from a jurisdiction. I believe it could be any non-California jurisdiction. I'm not fully well versed on all the reports that the FBI receives. We already are receiving this information for California-based criminal activity. In terms of other, the in-depth, details and nitty-gritty, I'm probably not the best person to ask about that. But when somebody submits their fingerprints, either a live scan or a hard card, if you're rolling your prints, then that information is provided to the California DOJ, and then some information about that is saved. So that way, then there can be an affirmative, connection and identification of, the Medical Board of California, ought to be receiving, certain types of information. It's very prescribed what the law states about what the board is able to get and how the board is able to use that kind of information, particularly with regard to the initial licensure. And there's a lot of law that says around what types of crimes, criminal activity, what type, how far back the board can look or be provided information with regard to, the history of such a person.
Okay. I think that this is for me, the major concern is about data privacy and data sharing, and just the fact that all this information is bought and sold so regularly, that I think midwives have a lot of concern about that, as well as, I don't think I'm alone in thinking that a lot of midwives are on a lot of watch lists for being political outsiders, I would say. And so
yes, we take a very careful look at whatever comes across us, and to make sure that it's within the bounds of the law, in order for the board to take any action against somebody's license.
Cool. Tight. Awesome. Thank you so much. Thanks for elaborating on that. Are there any other comments from the members or questions? Shall we go to public comment?
Yes, if anyone would like to make a public comment, please do so by raising your hand, or if you have would like to make a public comment, you can't find the raising hand feature, you can just type anything into that Q&A window. You don't have to type out your whole question, because we'll call on you to speak in just a moment. And if you're on a call-in only line, you can press *3 to toggle raising your hand. First question here we have is from Amanda Wynn. Amanda, you should be receiving that prompt on your end. And Amanda, if you're there, you should be receiving a prompt on your device there to unmute.
Can you? I think I got
go.
it done. Can you hear me?
Gotcha. Yes, we can. Please go ahead.
Thank you. I am filling in today for Rosanna on behalf of the Calm board. I do agree with the Madam Chair just about the AB 626. I'd be really curious to see. I think Calm would be interested, and we can talk more about that, about being part of the community and organizing, but just the screening doesn't necessarily do enough. And so I think that would be really an interesting piece. And then thank you, Mr. Boone, for your summary of the legislation related to midwifery. Calm was really pleased to co-sponsor AB 55, the Freedom to Birth Act. We had a great number of co-sponsors, legislators, members of the public that made calls. A lot of people sent letters to support this very important bill, which improved the access to care for midwives throughout the state. While the licensure is not required to operate a birth center staffed by licensed midwives, the birth center licensure is key to improving the access through Medi-Cal and insurance reimbursement. And so while it is not the whole answer to midwives getting reasonable payment, we're definitely making substantial headway, and that's really promising. So we're excited for that as a board. So that's all I have.
Thank you for your public comment. Next request here, our final request in queue actually is from Alex Rounds. Alex, you should be receiving that prompt on your end. If anyone else would like to make a public comment, please raise your hand now. Alex, you should be receiving a prompt on your end there to unmute. Okay, I'm not seeing Alex unmuting.
Hearing me yet?
There we go.
Okay, great. Well, thank you. Thank you for all the work you're doing with the council. I appreciate the time and energy, and in hearing around the perinatal screenings for perinatal mood issues, coming from a rural community and hearing the contributions of other groups of marginalized people. I wanted to really emphasize the need for community voice in frontier and rural communities, because we have birth and other inequities. We have populations of marginalized people who have that intersectional impact. And I don't hear a lot of rural community involvement and voice at the state level. So I just want to emphasize the need to consider rural impacts, the way that we implement any policy in a rural community. And when folks are coming from 2.5 hours from a small hospital, that's a pretty big challenge to get mental health supports and many other supports around perinatal care. That's it.
Thank you for your public comment. This time, I'm not seeing any additional requests in queue.
Thank you. This is a really good discussion. I'd like to move to agenda item number 7, which is the program update. Ms. Moriarty, could you provide us, please, with the program update?
Yes. Thank you, Ms. Weisner. Please turn to page 7A1 for the midwifery program licensing statistics. In the third quarter of fiscal year 2024-2025, the board received 6 new applications, issued 9 new licenses, and renewed 63 licenses. In the fourth quarter, the board received 11 new applications, issued 9 new licenses, and renewed 74 licenses. Please turn to page 7B1. In the third quarter of fiscal year 2024-2025, the board received 45 transfer of planned out-of-hospital delivery to hospital reporting forms for licensed midwives. The board received 40 in the fourth quarter. Please turn to page 7C1 for enforcement statistics for licensed midwives. In the third quarter of fiscal year 2024-2025, the board received 7 complaints and referred 0 for investigation. In the fourth quarter, the board received 10 complaints and referred 1 for investigation. Please turn to page 7C2. In the third quarter of fiscal year 2024-2025, the board received 0 complaints for unlicensed midwives and 0 were referred for investigation. In the fourth quarter, the board received 5 complaints for unlicensed midwives and referred 0 for investigation. Please turn to page 7C3 for enforcement statistics for transfer of planned out-of-hospital delivery to hospital reporting forms for licensed midwives. In the third quarter of fiscal year 2024-2025, 45 transfer of planned out-of-hospital delivery to hospital reporting forms were received, and 39 were closed by the board. 0 were referred for investigation. In the fourth quarter, 40 transfer of planned out-of-hospital delivery to hospital reporting forms were received, and 36 were closed by the board. 0 were referred for investigation. Please turn to page 7C4. In the third quarter of fiscal year 2024-2025, the board received 3 transfer of planned out-of-hospital delivery to hospital reporting forms for unlicensed midwives, and 0 were referred for investigation. In the fourth quarter, the board received 6 transfer of planned out-of-hospital delivery to hospital reporting forms for unlicensed midwives, and 0 were referred for investigation. Please turn to the 2024 California Licensed Midwife Annual Report Summary. For 2024, there were 613 midwives expected to report. Of those, the Department of Healthcare Access and Information received 370, leaving 243 licensed midwives that did not report. The total number of clients served during the year was 6,504, a decrease of 940 from last year. The number of clients who left care for non-medical reasons was 282 compared to 368 last year, a decrease of 86. 6 sets of multiples were delivered out of hospital. Page 4 indicates the number of planned out-of-hospital births at the onset of labor was 4,423 compared to 4,958 last year, a decrease of 535. And the number of completed births in an out-of-hospital setting was 3,744 compared to 4,174 last year, a decrease of 430. Pages 11, 12, and 13 identify the outcomes per county in which birth, fetal demise, or infant or maternal death occurred. Compared to last year, the number of deaths for fetal demise increased by 3 to a total of 23. The number of infant deaths decreased by 2 to a total of 2. And no maternal deaths were reported compared to one last year. Thank you. That concludes my update. Are there any questions?
Thank you. Thank you for your update, Ms. Moriarty. Are there any comments from the members? Questions from the members? It's a lot of information, huh? Are there any? Yes. Sorry.
Regarding required to report and number reported, what happens? So really, there were probably a lot more out-of-hospital births, is what I'm guessing as a consumer without, I mean, clearly this data doesn't really give us any insight because it's so incomplete. So I guess I'm just wondering, how did this come about? Like, what is it used for? Where is the data going? I'm just coming into this all new. I just want to have it somewhat explained, if possible, just so I have a better understanding.
Mr. Risley, are you talking about this is the licensed midwife annual report that's required for midwives to complete per statute? So that's where it came from. What's required to be reported, there's a framework set forth by statute, and midwives participated in developing what is asked of midwives to report. And the board cannot, under current law, discipline a midwife for not reporting but the board is informed of all the midwives who did not report, and there will be a hold placed on their ability to renew their license. The problem, of course, is that may prompt them to report, but it's late and their data may not, they may not get it in time for it to be included in the annual report. I hope that's helpful.
Sorry, I didn't realize I was muted. Yes, very helpful, thank you. And I'm curious where the data goes for this reporting. Like, what is it utilized for from year to year? Like, is it the perinatal data registry, for example? Like, where does it go? So, I mean, one thing, I guess, if it's incomplete, it doesn't really help to show. I guess I'm just wondering what the purpose is. If it's incomplete, and I'd like to know where it goes. I'm just trying to understand the overall purpose, other than I understand it's in statute.
It goes to HCI, which collects data, and then the board reports it every year to the MAC and also posts information on its website. And you know, it could be used presumably to support legislation, one direction or another. I'm sure Ms. Weisner and other MAC members may have comments on its usefulness. Ms. Weisner did present at the last MAC meeting on the LMR, but that's where it goes. It goes to a state entity that collects data.
Ms. Rosalie, I'll add a little bit of context here, if I may. Ms. Webb stated that the LMAR or that the reporting questionnaire was developed in council with midwives, and I'll say that that process was extraordinarily contentious, and many midwives felt that there was a significant lack of transparency around this requirement, and that the data would likely be used for punitive purposes toward midwives, since there was not a similar reporting requirement for physicians who were providing maternal care. And in 2013, when the LMPA was adjusted, the OSHPD statistics were in fact used by the California Medical Association and the American Medical Association, who then floated the idea of ending licensed midwifery in California because of that OSHPD data. So while it doesn't directly lead to disciplinary actions to individual midwives, collectively it's poorly representative of what the actual statistics are, and it can be used by those lobbying groups who are seeking to limit our scope of practice.
Thank you for clarifying that. I really appreciate that. That's all I have. Thank you.
Any other comments from the members? Cool. Shall we go to public comment?
Yes, if you'd like to make a public comment here on agenda item number 7, you can do so by raising your hand. If you'd like to type anything in that Q&A window, we can call on you if you do that as well. And if you're on a call-only line, you can press *3. First request here is from Amanda Wynn. Amanda, you should be receiving that prompt on your end.
Yes, I think I'm on mute again. I just wanted to let everybody know that Missy Cheney will be doing a presentation on the LMR to review the findings and the recommendations that she has for data collection opportunities, which would fill kind of the gap for MANA, which is quality improvement and then research purposes. So Calm will be hosting that, and there will be a registration link on our website in the next week or so. So just a heads up about that.
Thank you for your public comment here. Next request was from Holly Smith. Holly, you should be receiving that prompt on your end.
Hey, can you hear me? Sorry, I was a little bit slow on my computer.
You can, Holly, go ahead.
Great, thank you. My name is Holly Smith. I'm a nurse midwife in California. I'm also one of the co-leads of Midwifery Access California, as well as I am the project lead for the Community Birth Partnership Initiative at CMQCC. And just, felt the need to give a little input on the data collection. I'm so happy to hear Amanda say that COM will be hosting Missy Cheney to talk about this data collection tool. In my opinion, this data collection tool has no use. It isn't useful because you can't connect information at all between what happens with the infant to the birthing person during a transfer. You have no idea what happened on the other end of that transfer. You can't even calculate raw numbers because it will say that there were so many transfers and one was an infant transfer, one was a maternal transfer. But what if they were both one transfer happening at the same time? Does that count twice or once? Like you can see how just a PDF version of just counts is completely not useful. And obviously this was created to be, check in on midwives and potentially use it for punitive reasons. My suggestion to the Medical Board of California is to use what data is meant to be, to find a way to use this data for what it is meant to be used for, which is for quality improvement, which is for finding gaps that can be worked out legislatively, policy-wise, and for helping midwives build public trust and build collaborative relationships. The only way you're going to do that is to have a system that accurately collects the data and transparently reports it. So I would suggest that in a sunset report, the medical board make it known that this statute should be altered in some way to allow for that to happen. For example, through the California Maternal Quality Care Collaborative, which already pulls in data from every single hospital maternity hospital in the state, connects it to vital records data, and could easily create a system where you could connect midwives to data, to transfers, to outcomes, and then that would actually be utilizable and have an effect and could actually be one of the first of its kind in the nation, in addition to what Washington is doing to have really accurate data that can be used for something that is for patient good and for the good of midwives. I would also say that it's also just really poor public health reporting. For example, if you look at that LMAR and the medical board, I do think that it is your responsibility to remove the things from the report that could potentially identify a singular midwife and also potentially identify a singular patient as a HIPAA violation. Right now, you can look through there and see county level data, and you could see a maternal death and a neonatal death. That is really easy to identify a midwife and a person that happened to just by having that public health data. And it is clear that nobody reports anything that has an N less than 10. Is just really poor public health reporting, has the potential to be utilized in a way by stakeholders that's bad for midwives and bad for patients. So just from my end, I think in the very near future, those data points should at least be removed from the medical board's reporting. And then you all should really be thinking about how in the future we can do this better. That's all.
Thank you for your public comment. Last request here we have in queue is Alex Rounds. Alex, you should be receiving that prompt. If anyone else would like to make a comment, please raise your hand now.
Yeah, thank you for that. Thank you, Holly. That well stated. Another aspect of concern, well, at least a consideration, is in looking at the medical board site where LMARs are reported, there is not a 2024 update on the site where the other LMAR reports are for the last 15 years or 14 years. So it's hard to look at the data on a small screen. So it'd be great to have that accessible as long as we are using that data, that it should be publicly available.
Thank you for your
public comment.
At this time, I don't see any additional requests in queue.
Awesome. Thanks, everybody. Moving to agenda item number 8, discussion and possible action on 2026 Midwifery Advisory Council meeting dates. We have sets of dates that we get to vote on, and I'm first wondering if anyone has any like burning opposition to any of these dates. We all planned so far ahead that it's I've been actually really impressed at how like easy the scheduling has been, considering what we all do for our lives, you know? Okay, so we have January 8th or January 15th. Does anyone? Okay, January 8th it is. Okay. And April 9th or April 16th? I don't even know what the holidays are, but I'm going to
I'm
make
sorry.
this decision.
I'm
Pipes up.
sorry, Ms. Weisner. Can I go
Yes.
back? It looks like you might have an outdated agenda item 8. The dates are actually, the dates are actually January 15th or January 22nd.
Oh my gosh. I really do have an outdated agenda. Okay, but I cannot see that small. Okay, good. We're doing good. Okay. So what we're going to do is we're going to go through the dates, and if no one says anything, I'm going to pick each date, and then we're going to put it to a roll call vote, yeah? For the slate of dates. Sound good? Okay. So we have the 15th or the 22nd. I prefer the 22nd. Does anyone disagree with me? Okay. April 9th or April 16th? 16th? Let's do April 16th. And let's see. Let me move my little face box. September 10th or September 17th? Does anyone have any deep, deep desires one way or another? All right, September 17th it is. Okay, so are there any questions about these dates or comments from the members? Are there any public comments on these options for dates?
If anyone would like to make a public comment, you can do so by raising your hand now. Not seeing any requests this time.
Cool. All right. May I please have a motion to approve the dates of January 22nd, April 16th, or September 7th for the 2026 MAC meeting dates?
That's September 17th. I'm sorry, you said September
17th. September 17th, 1-7.
Thank you.
Motion to approve.
Hey, can I get a second?
I second that.
Thank you. Ms. Moriarty, can you please perform the roll call vote?
Yes. Faith Freeman,
Yes, approved.
Dr. Kenneth James,
I approve.
Karen Rosley,
I approve.
Mason Wilson Tanev,
Approve.
and Madeline Weisner.
Yes.
Thank you.
All right, the motion carries. Thanks, everybody. Moving to agenda item number 9, we have a presentation on frequency and rationale of free birth from Ms. Wilson Tanev.
Okay, thank you very much. I can't remember exactly how this came up. I'm sorry. Yes?
I've passed you the presenter role, so you should be able to use the share icon down at the bottom of the WebEx screen there to present the slides, but I have them ready if you prefer me to do it.
Okay, I'll go ahead and share my screen if that's okay.
Just let me know if you have any problems.
Let's see. I don't know that I've ever shared using WebEx. That may actually, am I able to share PowerPoint?
Yes, when you select that share button down at the bottom, you should have the option to share either just the PowerPoint application or your whole screen, whichever you'd prefer.
Okay, what I'm coming up with is, let's see. I do not see the option to share a PowerPoint. Go ahead and, since you have the slides,
Sure.
would you mind doing it for me? Fantastic.
Just let me know when you'd like me to advance the slides.
Okay, sounds good. So I don't remember exactly how this came up last time in our discussions. We had some discussion about Freebirth, and this was an area of research of mine in 2022. And so I thought I would bring some information to the Midwifery Advisory Council, to the public. My name is Mason Wilson Tanev. I am a licensed midwife and a doctoral candidate at California Institute of Integral Studies. Today, I'm interested in presenting some findings from original research conducted in 2022 for my master's thesis investigating why families are choosing free birth in California. That is, births planned at home without a licensed or medically credentialed attendant. So free birth is a rare but increasingly visible practice, and during and immediately after the COVID-19 pandemic, families reported heightened interest in free birth, often as a last resort after feeling excluded, coerced, or abandoned by the maternity healthcare system. This presentation draws from 24 in-depth interviews I conducted in 2021-2022 with free birthing families, licensed midwives, non-licensed midwives, and adults who were born by free birth. Next slide, please. So the key reason why families choose free birth, from these interviews, 5 primary motivations emerged. Families' autonomy and control. Families want the freedom to decline procedures. They want the freedom to extend pregnancy beyond the 42-week regulatory cutoff that was established in 2013. And they want the freedom to shape their care without fear of being dropped from care by their midwife. This fear of abandonment came up over and over. Second, distrust of both medical and licensed midwifery systems, which I'll say has only increased in the years since since I did this research. So families described coercion, unconsented procedures, and midwives prioritizing license protection over parental wishes. And just to clarify, when I say unconsented procedures, these were families who felt coerced into having inductions at the 42-week mark, or having lab tests that they did not find value in and had to pay for. I consider coerced consent a lack of consent. So just a note here about terms. Third, the fear of abandonment. And again, this came up over and over. Some families were discharged by their midwife late in pregnancy due to regulatory restrictions, particularly around that 42-week gestational age restriction, leaving them without support. So a licensed midwife can only care for a family until the 42nd week of gestation. And that means at that 42nd week, we have to recommend that we have to transfer their care. Now, they do not have to actually have an induction in a hospital. And for a lot of free birthing families, rather than transferring care to a medical provider, they went on to have a free birth. So then there were COVID restrictions. It was the time of COVID, mask mandates, limits on partners or doulas, hospital uncertainty led many people to seek alternatives. Since the lifting of masking and distancing policies, however, distrust of institutionalized credential healthcare providers has only deepened. And finally, a smaller group made a positive philosophical choice, viewing free birth as an affirmation of bodily sovereignty and intuitive capacity rather than it being in opposition to the restrictions of licensed midwifery. Okay, next slide, please. To illustrate these themes, I will share some brief quotations. One mother explained, "Licensed midwives are beholden to the state, not to me." Another told me, "I would have loved a midwife, but only if I knew I could say no to something without being dropped." And yet another suggested that midwives bring fear into the birth space. So next slide, please. Here are some statistics. 13 free birthing families, 5 licensed midwives, 2 non-licensed midwives, and there were unintentional free births. All of these families went on to have secondary births that were intentionally planned free births. So I included them because it was an interesting situation where they had a precipitous birth, then decided not to hire a midwife this next time around. Okay, next slide. So frequency estimates, how do we know how many people are having free births? And the answer is we don't. Accurate statistics are difficult to ascertain due to misclassification on birth certificates. Also, I think it's really important to keep in mind that not all families are upfront about their free birthing. They could potentially face carceral engagement if there's a perception of child endangerment. And so it took a lot of trust for these families to talk with me. And I'll say that while some are very active on social media, others are very quiet about their practices, which further complicates the gathering of accurate statistics. So about 1% of births occur at home. Nationally, of these, 1/4 are recorded as unattended. However, this category does not differentiate between free birth, precipitous birth, and misclassified midwife-attended births, thereby limiting accuracy. In California, midwives often do not sign birth certificate paperwork at the Office of Vital Records, and partners are sometimes listed as attendants, further muddying the numbers in our state. What we can say with confidence is that the interest in free birth rose during COVID-19 and since, and both midwives and families are reporting more inquiries. My research since 2022 suggests that intentional free birth is on the rise nationally and internationally, where statistics are gathered, particularly in the UK. Next slide, please. These findings highlight a critical tension in professionalization and licensure that we would do well to pay close attention to, and reveal the ongoing challenge of how to cultivate systems of care that both recognize midwives as autonomous providers and assure accountability and a base level of competence. Mandatory licensure was intended to increase safety and access, yet families report, paradoxically, that licensure creates regulatory pressures that midwives must prioritize, sometimes at the expense of client autonomy. The 2013 removal of the autonomy clause represents a pivotal shift in California midwifery regulation. This change prohibits licensed midwives from continuing care when families decline specific tests or procedures, even when those families are fully informed of the risks and willing to accept responsibility for their choices. From this client perspective, this discontinuation of care is frequently described as abandonment. My research suggests that fear of abandonment, particularly at that 42-week gestation mark, is among the most common reasons families either exit midwifery care or pursue free birth to avoid licensed midwifery altogether. And I will say that we don't have accurate statistics about how many babies are born by intentional free birth. We don't have statistics about their outcomes either. But I think all of us can suggest that while birth is largely safe and normal, not having the information to know when a transfer might be appropriate can only compromise the safety of both mother and baby. So while I want to reinforce that birth is very safe, birth without an attendant is less safe. So we'll just make sure that we understand that as a background here. So this narrative of unintended consequences. While the restriction, especially to 42-week gestation, was enacted out of legitimate concern for potential fetal complications, the practical effect has been to increase the likelihood that mothers and infants will give birth without a trained attendant, exacerbating rather than reducing risks to the mother-baby dyad. So next slide, please. I propose 3 areas for consideration. One, that the medical board consider supporting the restoration of autonomy protections so that families may decline interventions without forcing an end to midwifery care. And to support harm reduction approaches that allow midwives to stay present with families rather than pushing them to birth entirely alone. And to encourage collaboration over surveillance between midwives, physicians, and families, and to build trust rather than fear. And here, back to Ms. Smith's point, we might really reconsider the use of the LMAR. Next slide. And in conclusion, families are not choosing free birth because they underestimate the risk, but they feel coerced and unheard. Most of those families would prefer a midwife. That was a surprising outcome of my research. Many of I think all but 3 of those families said they would prefer to have a midwife there. But they didn't trust midwives. They trusted that midwives would protect their license instead of protecting them. And that by addressing these gaps in policy, the medical board can reduce the numbers of families exiting the system altogether while promoting safety and trust. So in order to address these unintended consequences, I recommend that the medical board seriously consider, again, the restoration of that autonomy clause to the Licensed Midwifery Practice Act. This would allow families to decline interventions and permit midwives to remain in care, guided by informed consent and, as it was before 2013, best clinical judgment. Since a change would not eliminate safeguards for maternal or fetal health, but would reduce the number of families turning to unassisted birth out of fear of abandonment. In effect, this adjustment would promote safety by ensuring that more California families have access to trained professionals at every stage of labor and birth. And I would be happy to answer any questions if you have any.
Thank you so much for presenting on this and for your research on this. Are there any comments or questions from the members? I think it's all information that midwives and midwifery consumers are aware of, and very, like, we see this every day in practice. We see this certainly with every informed consent conversation when someone goes past their due date of like, yeah, 2 weeks until my regulation requires me to leave you, to leave this relationship that we've spent months building together. I'm really glad that you have brought this to the MAC meeting and that it's on record and that your research is being shared in this way. Thank you so much. Shall we move to public comment?
If anyone would like to make a public comment here on agenda item number 9, you can do so by raising your hand or type anything into that Q&A window. If you're on a call-only line, you can press *3. First request here is from Amanda Wynn. Amanda, you should be receiving that prompt on your end.
Thanks so much for presenting that. I think that's really valid information. Do you have a way to look at your paper and your research to share that with everybody?
This is pre-publication, but when it's published, you'll all get to see it. I would be happy to send you my thesis if you're interested in reading 60 more pages of it.
No, I think this is really valid information, and I'm thrilled that you took that research approach. And I think it would be great for when it's published and when you're able to share that for it to be out there, because I think it's a very prudent topic. Thank you.
Thank you for public comment. At this time, I'm not seeing any additional requests.
Okay, thank you again. Thank you so much for sharing that. Moving to agenda item number 10, we have a continuing discussion on environmental exposures faced by midwives. At the most recent MAC meeting, I chatted about licensed midwives and our unique role in disasters, not causing them, but helping during them, okay? And the fact that we serve as first responders in natural disasters and other crisis situations. While we did not get an item on the agenda with a presentation surrounding this, I do just want to reiterate that these crisis events, such as wildfires, act as health threat multipliers. And the best available research shows that pregnant people are the most clinically vulnerable population in crisis events. These events continue to intensify existing inequities in our communities. And they really do place disproportionate strain on families, as well as the midwives working with them. And unfortunately, like by all estimates, climate catastrophe is building and these events will keep coming and keep becoming more frequent and less predictable. So I did want to remark that ICM, the International Confederation of Midwives, does have a new digital toolkit that has messaging specific to midwifery involvement in crisis planning. These may be particularly useful to licensed midwives who are in areas frequently impacted by natural disasters like wildfires, like landslides that cut off access to a third of the state at times. I've lived up the 101, I know this for a fact. As we all know, all of California is really vulnerable to climate change. This needs to be a statewide conversation with emergency planning office, as well as hopefully with support from the medical board on any legislation that might come up. Are there any questions or wanting any further discussion on this from the members or experiences you'd like to share? All right. Shall we seek public comment on this agenda item?
If anyone would like to make a public comment, do so by raising your hand. Type anything in that Q&A window. If you're on a calling line, you can press *3. Give you a few seconds to see if anyone queues up. Okay, here we have Amanda Wynn. Amanda, you should be receiving that prompt.
Sorry, I'm talking a lot today, I see. I don't know if the other midwives that are on the call are familiar with it, but the National Certified Professional Midwives did do a wonderful training that was available for wildfires. I did that a couple of months ago, and so that is one that if we're looking for information, or if the medical board wanted to kind of look at it, or we wanted to look at it, I would highly suggest using. I found it really informative, and they had a lot of tools in that presentation that would be able to just piece together for a toolkit too.
Thank you.
Thank you for your public comment. This time I don't see any additional requests.
Awesome. Thank you, everybody. Moving to agenda item number 11, discussion on the midwifery payment model. And I really hope that Holly Smith is still listening. I want to make you proud, but I also want you to call in and talk more about this. I just wanted to touch a little bit on this because it is asked about very frequently. This is a payment model developed by Midwifery Access California. As we know, insurance companies often reimburse care provided during the childbearing year through outdated payment models that prioritize patient volume and productivity. Midwives are currently required to use billing and coding systems that were designed by and for physicians within the dominant model of maternity care, which includes brief episodes, brief appointments, collaboration from a lot of facility-based services like registered nurses, like respiratory therapists, like a lot of different professional input. These systems don't account for the really significant care coordination and patient education and face-to-face time that we spend with clients, all of which are so central to the midwifery model and to the definition of licensed midwife care, but they're just simply not reimbursed in the current billing system. Payment redesign is really necessary to improve access to midwives, and we've talked a lot about this as long as I've been on the MAC. The current payment model is not working, and midwives are quitting, and people are not seeking midwifery care because they cannot afford it, and this is a cycle that is just running everybody into the ground currently. So through this alternative payment model known as an APM, developed by Midwifery Access California, a midwifery practice, so a individual midwifery provider or group practice would receive bundled payments at specific points in each client's pregnancy episode. These are known as bundled episode payments, and these are used in a lot of other aspects of healthcare very readily. Gallbladder surgery or mental health services use these a lot. So this is not a new idea. It is a new application for maternity care. So some of these episodes of care that were developed in this payment model development include an entry to care bundle, which would include doing the initial history, the initial head to toe physical exam that midwives are so good at and know so much about, and initial ordering initial bloods and ultrasounds for these clients, confirmation of pregnancy, socio-cultural assessment, socio-emotional assessment, behavioral health screening. This would all be encompassed in the entry to care bundle, okay? And then there are antenatal or prenatal care bundles for first, second, and third trimester. So if someone enters into care late, say it's based on their gestation at entry, there's also a bundle for being on call when this person is pregnant and when they are term. Most midwives go on call 24/7 for labor at 37 and 0. But as we all know, we're also on call for 3 a.m. tummy aches at 18 weeks. So these bundles account for the extreme amount of work that individual midwives and midwifery practices do. There's also a triage bundle, labor, birth, and immediate postpartum bundle that includes all of that face-to-face care, all of the early labor assessments and phone calls, all of the like monitoring that happens in labor that midwives usually single-handedly are doing, intermittent auscultation, vitals and observations, labor support. This bundle includes that, as well as postpartum and newborn dyadic care bundle, because as we know, licensed midwives are the primary care provider for the parent once they have birthed, as well as for the newborn baby for weeks after they give birth. So while this model was originally developed by MACA as a solution for Medi-Cal billing, this model is really usable for any midwifery practice in the community. Home birth, birth center, even co-care models, this could be easily applied to it. I'm not suggesting specific fees because that is like a violation of federal antitrust laws, but also different regions and different providers have different market forces at play, different options for care in general. But the APM that is on the MACA website, if you look at it, it has sample amounts. This was intended to be used in a Medi-Cal setting. So those dollar amounts are based on what the math added up to be an appropriate reimbursement at the time of its creation. However, healthcare costs, even since this payment model came out, have skyrocketed. So this model could be a really meaningful way to structure even individual licensed midwifery practices so that all of their care that they're providing is compensated, and to reduce like refund drama that can happen with home birth clients and with clients who need to leave care for whatever reason. A lot of midwives have reached out to me about their fee structures and about their refund policies. And I think that this is a very excellent, very well thought out, fit for purpose model that even individual providers could use. But to be clear, it was not intended to be used for that. It was intended for the Medi-Cal setting. You can read an executive summary. You can read like a quick SparkNotes version of this APM on the website midwiferyaccessca.org. But it's definitely something that I want more people to know about because it's really revolutionary. Other countries, like some of you know, I live in New Zealand. We have this written into our statute here. Like, this is how much midwives get paid, and this is what the care includes. And it's not perfect, but it's way better than California. And it has given rise to a really incredible integrated system where people know exactly what midwifery care they're going to get and what their midwife can and cannot do for them. So take a look at the APM. What questions do the members have about this? Have you heard of this before? Yeah, cool. It's interesting. I think that one thing that we found in the creation of this APM is that the cost to the midwife is higher than the cost that most any pregnant person can afford. And so I think that there's really good information there of like a sustainable living wage for the healthcare provider equals an unsustainable cost for the patient. And how do you reconcile that within a for-profit health system? That is another conversation, but the APM is a really good start. I would recommend it to new midwives who are figuring out how to work their practices, especially. And yeah.
Ms. Weisner, I have a question for you.
Yeah, yes.
This was originally developed for the Medi-Cal system. Have any of the private insurance stakeholders had anything to say about this? Have any billing agents weighed in?
So
Would
I
this
think
change how it's billed, or just how it's just the private exchange of finances between midwife and client?
so. This was built within an APM framework that follows all of these like high-level insurance billing categories and terminologies so that it could be utilized in a claims setting. So we got input from the Medi-Cal managed care plans on it, and also one very cool, very like revolutionary thing about it was that the input was considered, and the midwives creating this APM were like, we're making this about midwives. We're not making this about insurance companies. We're doing this is the extent to which we are willing to work around you all and your computer structures, but this model directly centers midwifery care and midwifery consumers in how the financing of this care is created. Does that make sense? So there was input from some of the managed care plans, and these plans are members of Midwifery Access California. So they're at the table, they're talking about this, they're listening to the midwives and the other stakeholders at the table and trying to find solutions of how this could work in an insurance setting. But I don't want to speak for them about like when they're going to be rolling it out, because I don't know, and I don't know if they will do that. Midwives and consumers can be a part of MACA as well if you want your ear in these conversations too. But the APM is available online for anybody to take a gander at. It's very easily, it's easy to understand, and there's more detail than I can eloquently present here. Other questions? Is this anything that you guys like to see? It is yet another aspirational model, but I think it's pretty sick, right?
And since it's care, it's bundled care.
Right.
So it's also along the lines of revolutionizing the whole billing system to go towards a more value-based care system.
Yes,
And that's
absolutely.
an
And
important piece.
yes,
I
and
understand.
part of the aim of using this would be to incentivize plans to let them know that this is higher value care. One conscious decision that was made in its creation was not to devalue midwifery care by saying, oh, it's more cost effective, because we don't want to cheapen midwifery care. Midwifery care is like so valuable, as we know, right? So we don't want to be promoting midwifery as a cheaper alternative to physician-led care. That is not the way to go about doing this. The way to go about doing this is to say, you know, you are going to waste so many administrative hours adjudicating line by line claims for every single supply that is, every single lure lock, every single thing that is itemized and billed for in the current setting. Midwifery, Medi-Cal billing, I mean, I'd say for each of these episodes of care to Medi-Cal managed care plans, I'm submitting at least 30 claim lines, and each of those has to be manually examined by the person adjudicating the claim, right? So I think that when we're talking about value-based care, we're talking about the added value, of course, of like gold standard maternity care and patient satisfaction and better outcomes and lower risk of needing hospitalization or rehospitalization that is very, very costly. But the providers themselves are not less expensive. And so it's interesting. I mean, I would recommend that you all read through the APM. I think it makes a pretty cool case. Sitting in on the MACA meetings is also very, it's very eye-opening, and it's very cool to hear conversations about value-based care transformed from the Kaiser model of, yeah, we're giving this great care, but we're underpaying our workers and overworking them and creating unsafe environments for them. It really creates a midwife and midwifery care centered approach to payment that is very cool. That's what I have to say about it anyway. I'm done. Questions about this? You all know how to look at it. You all know how to view it. You all have the internet. Cool. Shall we take some public comments?
If you'd like to make a public comment on this agenda item, please do so by raising your hand and type anything into that Q&A window if you like, or if you're on a call-only line, you can press *3. A few seconds to see if anybody queues up. First up here, we have Holly Smith. Holly, you should be receiving that prompt.
Hi there. Well, I'm super excited that this was talked about today. The midwifery payment model, the MPM, I guess some people would call it an alternative payment model, was created after about 1.5 years of focus groups and interviews with California midwives who are CNMs, LMs, who work in community birth settings in both home and birth center settings. We also had multiple conversations with other stakeholders, inclusive of Medi-Cal health plans. LA Care is one of the health plans in Midwifery Access California. That's the largest Medicaid health plan in the nation, as well as Blue Shield Promise and Partnership Health Plan. Recently, also CenCal Health Plan has become interested in the model. You did a really good way of describing everything that happened, Madeline, and why we created the model. And really what we started with was what makes midwifery different, and then what would make it sustainable. And what makes it different in comparison to the dominant model of care is that there are longer visits taking 30 minutes to 1 hour each time that you see a client. There's more visits. There's home support. You know, community midwives go to that person, meet them where they are. There's substantial lactation support, dyadic care with mom and the newborn, social support, comprehensive care management, 24/7 on-call care. And then I think what's, the most important during labor and birth, although labor is not the most important part of all of this. It happens that it's what happens during pregnancy and postpartum if we're just strictly talking about morbidity and mortality. But in terms of labor and birth, that continuity of the human presence with the same midwife throughout, I mean, you cannot find that in any other model of care. And when we looked at the numbers there, in terms of the sheer amount of time that a single midwife spends with a client through the course of pregnancy and postpartum is about 40 hours compared to 9 hours in the dominant model of care. And so obstetrics and midwifery are different. We offer different things. They're both valuable, and they both should be compensated in a way that allow clients to get the care that they desire. So in putting this together, we also realized that oftentimes stakeholders and policies makers will say, well, one way of improving outcomes is increasing access to midwifery care. But that's usually where the conversation stops, because everyone's like, okay, but how do we increase access to midwifery care? Well, actually, there's a few really easy things. One, you regulate state regulations and laws to allow for access to midwifery care. Okay, that's the first thing. Then you regulate so that midwives can practice to the top of their training and education, so that folks can see midwives not just for their pregnancy care, but for their GYN care, for their birth control, for problem visits that come up for the well person. That's what midwives are trained to do. And then at the very least, you mandate reimbursement parity to what the dominant model of care is being paid. And then when you realize that parity doesn't cover costs, for example, Medi-Cal, the community midwife will see a client throughout, and if they bill for everything and don't transfer that patient to a medical provider, they can only make about $3,000, if that. And through this payment model interview, what we discovered is that it takes at least $10,000 per patient to keep the lights on. So if there isn't parity, there has to, or if there is parity and it's still not enough, we have to realize that what midwives are providing is above and beyond in both hours of time, human time, as well as paying their staff, that it requires more reimbursement to create access to midwifery. And I think it's just something we don't really want to talk about is payment models. It's a little boring. Also, we can't talk too much about like who's paying who what, but at the end of the day, that is the one thing that will create access to community midwifery care. Not to mention that there's also questions of fairness. There are midwives in California who don't make a living wage. That's just morally wrong. And that shouldn't be the case in the time that we're in. I also know that we get a lot of feedback sometimes from physicians who are like, whoa, you want to be paid how much for a home birth or in a birth center? And our feeling is that although it's not always true that a rising tide will float all boats, we believe that by raising the value of, at least from looking from the outside in, the perspective on the value of midwifery care and paying for that will also improve payment rates for physicians as well, and will make us think about, as a state, why is it that orthopedic surgery or a knee replacement gets paid this much, thousands upon thousands of dollars, but we pay pennies for childbirth. I think it really just shows, it's a reflection of what we value as a state and as a nation. So in any case, all of this to say that there is one state that did mandate this. Minnesota recently mandated that freestanding birth centers would be paid the equivalent of regional hospital facility fees, the average of those regional hospital facility fees. And we'll be watching that closely. We suspect that will mean that there will be a proliferation of freestanding birth centers, and there will be better access to the kind of care that some people want. So midwiferyaccessca.org. You can see the MPM there. We've had interest by CMS and other organizations federally as well. So California's doing some cool stuff. That's all.
Thank you.
Thank you for your public comment. This time I don't see any additional requests.
Thank you. It's really nice to see someone else who's so excited about this. Um, moving on to agenda item number 12, which is a discussion on accessibility and sustainability of California midwives. We have discussed the midwifery payment model, which I think is like a huge new piece of information about this. We have also at previous meetings discussed like the education opportunities for licensed midwife training in California. As you all know, there are two schools that have received funding to train licensed midwives in California. This is after the closure of several direct entry midwifery schools in the US. And so perhaps Ms. Wynn from COM has an update on the Saracoso Community College program, which is the first of its kind in California to allow like Pell Grant funding for midwifery training, for licensed midwife training. I'm curious if anyone after our last meeting has some thoughts about accessibility and sustainability of California midwives and how we can better ensure that these crucial services are being delivered to families in California. Does anyone have any thoughts about that? That's okay. Shall we move to public comment on this agenda item? Are we going to call it discussed?
Sorry. Anyone like to make a public comment, please go ahead by raising your hand or type anything in that Q&A window. If you're on a polling line, you can press *3. First request here is from Amanda Wynn. Amanda, you should be receiving that prompt.
Yeah, I think that what we're seeing with Saracoso and also with the Song Brown, the Common Sense Childbirth School coming out is really, really exciting. I think it's going to offer a bunch of accessibility. I think it is going to really just be hopefully a huge change for California families and also for California midwives. And I'm really excited to see that the way that Saracoso is setting that up. I don't know if you want me to speak anymore on that, Madam.
We're not supposed to have back and forth with the public comments, but yes.
Okay, sorry. New to this. I'm excited that they're going to be paying their preceptors, which is something that I don't know of any other college doing. I also feel that the way that they're setting up the program and that they're having oversight by the public and by the profession is really exciting. The way that they're getting grant funding is really exciting. The way that they're increasing accessibility. Overall, I just feel like they're really approaching this, the concerns that we've seen with other educational schools and other educational programs in really different and dynamic ways that I think really is needed. And so I'm personally and professionally thrilled to see this happening. And I think it really will have a big impact, not only in California, but I'm hoping that they are able to do some virtual school programs and just, they're also not losing the piece that makes midwifery important, if that makes sense. They're really tapping into the local communities and trying to get the students connected with preceptors, which I don't see that anywhere else really. So anyway, I'm thrilled professionally and personally to see this going forward. And I don't know as much about the Common Sense Childbirth School, but just the fact that they're coming to California, that they are another option. I feel more options are just bring more diversity and bring more options as well. So I'm excited, and I know we are as well.
Thank you very much for your public comment. Next request here we have from Lisa Rawson. Lisa, you should be receiving a prompt there on your end.
Hello. Hi, my name is Lisa Rawson. and I actually sit on the advisory board for the Associate of Science at the Saracoso Community College. And yeah, we just recently put out a call for preceptors to fill out forms and begin answering their questions. We do have a FNQ on the CALM and the CAM, and on the college website as well. We're starting to get traction and a lot of inquest from students, which is really great. One of the things that everybody is really excited about is the affordability and also the availability of Pell Grants, which is amazing. And then also the hybrid nature of the program is exciting. But also the fact that, midwives are included in this. So we have MEEC and we have the medical board and we have the college. So we have this really unique oversight and basing it in the midwifery model of care while having this, structure of the community college, which is really great. And yeah, just keep looking at the websites for updates and send students that want more information to all of the websites, the colleges and CALMs and CAMs, and we'll be putting up updated information on a weekly and bi-weekly basis. So the meetings have been great. Meetings with the college have been really, they're a wonderful team over there as well. And it's really exciting. So just thought I'd give that update.
Thank you very much, Lisa. Last request here in queue is Holly Smith. Holly should be receiving that prompt. Oh, looks like she pulled her hand down real quick. Holly, sorry, did you have a public comment?
Oh, yes, I did. Sorry, thanks. I'll be really quick. You're asking about access. So obviously, what I talked about before, reimbursement is the key to improving access. But what comes to mind right now with maternity centers closing, especially, is hub and spoke models, which I know, Madeline, in where you're at is much more common. And I know it's a little bit more, midwives might have differing opinions on this because midwives love to do birth and want to do birth, but I do think there is room to thinking about and discovering ways in which centralized maternity care centers exist with this as the hub, with the spokes being midwife-led GYN and maternity care clinics, federally qualified health centers, private practices that escalate care when necessary so that people can continue to get care where they're at, give birth in the hospital setting if they desire to, or in a community setting if they desire that. And it would just be a more efficient use of all resources, plus giving amazing care. So I'll just leave it at that.
Thank you, Holly. At this time, I don't see any additional requests in queue.
Awesome. Thanks, everybody. Moving to item number 13, discussion on presentation to the board regarding midwifery history and updates. So previously we had talked about trying to get into the habit of doing trying for an annual presentation to the medical board on the practice of midwifery, just to keep us on their radar. I do occasionally go to the medical board meetings to get our agenda approved. Okay. So they hear the word midwife, but we had previously had a little chat about trying to do more frequent presentations to the medical board about what is a licensed midwife? What is the regulatory authority for midwifery, and keeping the voice of the stakeholders in licensed midwife care centered. And I think it's a good idea. Some ideas that were previously brought up about this included presenting to the medical board a very brief history of the regulation of midwives in California. Someone had had been suggesting presentations specifically on VBAC because that is a point of major discussion with licensed midwives, despite it being in our scope of practice and our training. And we're actually the only maternity care providers with specific training requirements for VBAC in California. It's very much something that people want to talk about a lot. So someone had also suggested the MAC could potentially use this as a way to better educate about our model of care, but also about enforcement and concerns that maybe consumers or licensed midwives have about the enforcement process. I'm not sure how feasible that would be or how much information I would be allowed to share with them. Other options that were pitched at the last meeting, including the MAC itself researching and potentially recommending a statute change, which we can't do, but which our professional organization maybe could do, but has expressed they don't really have the capacity to do that. This is in regard to the LMAR and the community birth data registry, which is one of the other data collection mechanisms that I talked about at the previous meeting. So perhaps the MAC could be here to champion such a thing, or could defer that to COM, or we could do a little bit of this, a little bit of that. There were some other ideas about just presenting to the medical board, like any legislative updates that might impact midwives specifically and how those impact midwives specifically. I think that come springtime, it's, there might be new bills afoot, new legislation passed, especially in regard to the perinatal screening. And then there was also a lot of talk about trying to increase engagement at these meetings, so that, and I'm actually very impressed today about all the calls in. It's feeling good, but it's nothing like 2015 MAC meetings, okay? Those things were epic. So anything that we can do to increase engagement, or that the medical board could do to increase engagement in these meetings, in addition to their routine banner on the website, agenda announcements, etc. So I'm curious if you all have any more ideas. And anything? I also wanted to ask if Ms. Rosalie had been given an orientation to the MAC yet, or if where we are on that one, that situation.
I believe I'm going to discuss dates when that could be done with Tanya after the meeting.
Cool, perfect.
For other
Awesome.
ideas, I guess as a consumer, I just keep going back to how underused midwives are in our system that already exists, without recreating a whole medical system. And I was, I guess, thinking in the area of postpartum care. They're already community workers. They're already working in the community, and along the lines of they need to be able to make a living wage. I guess I don't understand why hospitals will even hire doulas, not just contract with them, but yet licensed midwives who are at such a higher level they're not in existence at all in the system anywhere. So if there's an opportunity to think of future items to be discussed, I guess I would like to have that be considered.
Awesome. I've added it to the list. I think it's been very interesting to watch the unionization process at Kaiser has been interesting to watch, because in tandem wages for midwives have either been gone down or the contracts have been like progressively getting less excellent. And in tandem, Kaiser has been really onboarding a lot of doulas, particularly for like rather low wages or volunteer doulas. And it's very clear to watch this institutional shift of trying to get cheaper workers, basically, and trying to move in workers who fulfill a somewhat similar role, but who are striving to do it maybe not knowing that it's a poorer wage, or maybe just wanting to increase access at the cost of wages. But a number of people have contacted me about like, why all this talk about doulas all of a sudden? And it's not a coincidence that it's also at the cost of midwives. And we all really do have to be working together. With that point, I do think it would be helpful to present, if we're presenting to the medical board, to actually like talk about the difference between midwives and doulas, because every medical board meeting I've been to, like there are still people who can't grasp that basic concept of the difference. So yeah, thoughts on that, questions on that?
How is that information best relayed from us to the medical board? And how can I be helpful?
I feel like historically, like someone from the MAC has gone and done a PowerPoint at the medical board meeting where they're all forced to sit there and watch. And I do think that that would be probably better than forcing them to sit and listen to a public comment, which is often what happens between, you know, particularly with COM making statements. COM is not usually given an agenda item at the medical board meeting, whereas the MAC is sometimes. So as long as it's approved and everything looks really good. So so I think that the way to do this will be, when we're talking about future agenda items, to propose a future agenda item that is discussion and possible action, which was missing from this one, on a presentation to the medical board meeting upcoming. And then I will make a beautiful presentation that synthesizes the things that we've talked about here. I will pitch it to the medical board and they will decide if I may present that at a meeting or not. I think that that is the process. But it's something that we would all have to vote on as well. And that would be hopefully at the next meeting. Does that make sense? Okay, very cool.
I'll offer some additional context here, Ms. Weisner, if I may, and that is that you can certainly go through that process, and it would inform you if the board asks that you or another member of the MAC present, like what's important to the MAC to present. On occasion, the board has asked a particular presenter, can you come to this meeting and present on this topic? So that's another way that this could come about. So in that sense, there wouldn't have to be a particular action item if the board makes a request of a particular speaker to speak on a certain topic.
Interesting.
But this is another way where it's like, as the MAC, you're getting feedback from the other members on what topics are important to present to the board, and then you'll be asking the board, can we present on these topics?
Okay. I feel like I'm like asking for an invitation to a birthday party. That's how this feels, of like, can the medical board please invite us to do a presentation? Is that, or do you want, should I like write a letter or a PowerPoint? I'm
the
really
request
bad
is
with
noted.
the quorum of this. Okay, thank you. Cool.
Yeah.
Thank you. I really appreciate it. Thanks for helping us all save time and move this along. I do think it might be intriguing to see what the medical board members want to know. I think that would be an interesting memo to read, just to be able to identify any like basic knowledge gaps. I think that a lot of the time we have the conversation of like, oh, you're thinking of a doula and we are midwives, or oh, you're thinking that what we're trying to do is illegal, but actually you guys like oversee us and the legal practice of midwifery, right? So I don't know if there's a way to elicit like feedback on what they could learn the most about, or if we should just give them the old survey of topics of interest for licensed midwives. I don't know. I'm sure someone will let me know. Yeah. Maybe. Okay, cool. Thanks, everybody. Shall we move to public comment on this agenda item?
If anyone would like to make a public comment on this agenda item, please do so by raising your hand. You can type anything in that Q&A window, or if you're on a call-only line, you can press *3. First up here, we have a request from Leslie Nelson. Leslie, you should be receiving that prompt.
Can you hear me?
We can, Leslie, please go ahead.
Leslie Nelson, licensed midwife. And years ago, I spoke to the medical board and they didn't know that we sterilize instruments. So that would be one of the things you need to tell them. That was one of the things. I remember years ago that the MAC meeting pretty regularly, maybe it was a presentation. Anyway, I think it's a very good idea to be doing, honestly, a presentation at every single medical board if we possibly can, saying the exact same thing every single time about what we talk about at the meetings, about what our complaints, what our problems are as midwives. Not getting reimbursed, lack of autonomy for the mothers. Yeah, those things. I think it's a good idea. Thank you.
Thank you for your public comment. At this time, I'm not seeing any additional requests.
Awesome. Thank you, everyone. Thank you for hanging in there. We are doing so good. We are so close to being done. Okay. One of the really the last discussion topic that we have is agenda item number 14 in regard to the Community Birth Partnership Initiative. This is a statewide program to improve relationships between community midwives and hospital providers. It's a large-scale effort to improve processes for transferring our clients between community birth sites, such as the client's home or a freestanding birth center, and the hospital. Currently, they are focusing on 4 regions, with these pilot sites informing expanded work across the state. This is very cool stuff happening here. Hospitals in the greater Sacramento area, Inland Empire, San Diego County, and Mendocino County are working with community midwives from their respective areas, as well as the Community Birth Partnership Initiative people. Some of the things that these groups are doing include virtual learning sessions. They're co-designing policies for transfer so that the transferor and the transferee are all on the same, or the recipient of the transfer are all on literally on the same page document. They also run simulations. They conduct patient experience surveys and let that kind of inform this process. And they're also engaging EMS providers to play an active role in policy and planning. So I just wanted to say that if anyone's interested in participating in this somehow, or if you work in a facility and you want resources for home birth transfers, if you're a physician or a registered nurse, or anyone else working in facility-based maternity care that wants to be able to strengthen this this service for these women and these babies, especially NICU. Like if you're in a NICU and you want to strengthen transfers between home and NICU, please visit the CMQCC website, cmqcc.org, and there's a section on the Community Birth Partnership. That's all I have to say about this. Do any of the members have any questions or comments or experiences? Like, have you interacted with this initiative in your region at all? Did you know it existed? Cool. Awesome. Well, as far as I know, all their resources are for free too. CMQCC is top of the line. Very cool. Are there any public comments on this agenda item?
If you'd like to make a public comment on this agenda item, please do so by raising your hand. You can type anything in that Q&A window, or you can press *3 to toggle if you're on a call-only line. First request here we have is from Alex Rounds. Alex should be receiving that prompt.
Thank you. Alex Rounds, licensed midwife in Mendocino County, and I just am so grateful for the CMQCC and CBPI program and involvement with EMS services, especially in this large county with like 3,600 square miles, some very frontier communities, having involvement of EMS, and the small only hospital in the county that offers labor and delivery is it's a delightful opportunity, and we're really just excited to see it through. We'll hopefully have more to share as we move through the program and improve our relationships with all of the providers in the county that are involved with perinatal care. So just a wonderful opportunity, and so far very easy to get engaged. So if your community is interested, I think there's the communication is really simple, smooth, and supportive with the CBPI.
Thank you for your public comment. Next request here is for Leslie Nelson. Leslie should be receiving that prompt. Excuse me.
Can you hear me okay?
Yes.
Yes.
Yes, we
Thank
can.
you. Leslie Nelson, licensed midwife, and I participated in that process here in Sacramento and also in the Yolo County area as well. There were two parts to it, two pods, but I was in both pods along with my midwifery partner, and it was so fantastic. One of the most fantastic things I've done in my midwifery career, and I highly, highly recommend it. It will change how things happen, and has changed how things happen. And in 6 months, it's incredible. So highly recommend. Thank you.
Thank you for your public comment. Next up here we have Lisa Rawson. Lisa, you should be receiving that prompt.
Hello, I'm a licensed midwife in Mendocino County as well. Hi, Alex and everyone. And we are really excited about that program. And it's been a game changer. I've been there for over 10 years and it's really making a difference. I also work at the California Birth Center in the Sacramento area, in Rockland, Roseville. And the program that we have with the hospitals in my area, and in that dynamic, you can see a huge difference in not only the outcome, medical wise, but also just the satisfaction and the ease of transfer, and the referring back part as well is really, it's just outstanding. The difference is night and day when we're working with hospitals that don't participate in that program and hospitals that do participate in that program, not only for us as the licensed midwives and care providers, but also for the clients. There's been a lot of education on both ends, and it's just been really fantastic. And Holly and her team are amazing. I just would like to say that. Yeah.
Okay, thank you, Lisa. This time I don't see any additional requests in queue.
Awesome. Thanks, everybody. It's good to hear such good feedback about what's happening, and I definitely hear that feedback from patients as well. Moving to agenda item number 15, future agenda items. Future agenda items. So sounds like maybe we need a agenda item of discussion and possible action on a presentation to the medical board, but maybe we don't. Maybe we do though. You know, I love agenda items. Should we try to get up to 20 for the next one? No? Anyone? Okay. So I would propose that agenda item. I think we also have a standing agenda item of Medi-Cal task force update.
I can go over the standing agenda items if you'd like, Ms. Weisner.
Thank you.
Okay. So we have approval of the minutes, report from the MAC chair, update on midwifery related legislation, program update. I also have the report from the task force on the Medi-Cal related issues, and I have discussion and possible action regarding a presentation to the board. I wanted to let you know as well that in the April meeting, we will have 3 MAC members that are their term expires next year on June 30th of 26. Madeline Weisner, Dr. Kenneth James, and Mason Wilson-Tenev. And you are welcome to apply again if you're interested in serving a second term. I just wanted to bring that up as well.
Very cool. How exciting. Would that mean that any members of the public who are interested in filling these roles should apply? Are the applications up on the site?
They are not posted yet, but they will be posted. And this will be at the April MAC meeting. You'll be voting at the April MAC meeting.
Okay. Awesome. Thank you for the heads up on that. Appreciate it.
You're welcome. You're welcome.
And awesome. Very cool. Do we have any proposed agenda items? I was joking about making there be 20. I don't want that either. Do we have any proposed agenda items for the next MAC meeting? That sounds like a no. Shall we go to public comment?
If you'd like to make a public comment for future agenda items, please do so by raising your hand or typing anything in that Q&A window, or if you're on a call-in-only line, you can press *3 to toggle that. Give you a few seconds to see if anyone queues up. First here we have Leslie Nelson. Hopefully you should be receiving that prompt.
Leslie Nelson, licensed midwife again and still, and my I just want to make sure that it will be on the agenda to shoot. You guys were talking about the alternative to the LMAR. That will be on the agenda item, correct?
Ms. Nelson, there's not a back and forth, but it sounds like you're making that request as an agenda item. So okay.
Yeah, I can't remember what exactly guys were talking about, but the alternative to the LMAR, or somehow getting that to, if we could get rid of the LMAR and do something that's useful, that would be awesome. Thank you.
Thank you for your public comment. This time I do not see any additional hands raised.
All right. Thank you everyone for all of your time today. This was really great. I hereby adjourn this meeting. I hope you have a great evening.